My topic of presentation is prevalence of osteoporosis in macroprolactinemia and hyperprolactinemia and correlation with estrogen levels. Prolactin, which is an hormone to promote lactation, which is synthesized and secreted mainly by the anterior pituitary lactotroph cells. Besides this, it also has extra pituitary sources like skin fibroblast, spleen, thymus, breast, prostate, etc. This hormone prolactin is critical to establishment of lactation, milk macronutrient content, and milk production. Beside this, it also has more than 300 separate biological activities. Prolactin molecule, which is synthesized as a single gene of 10 kb size on chromosome number 6 by the anterior pituitary gland in the form of 227 amino acid prohormone, which is finally broken down into the active prolactin of 199 amino acid. Besides this free prolactin, there also exist big prolactin as dimers and big prolactin molecules as complexes of prolactin with immunoglobulins and prolactin aggregates. Now, these are the big prolactin, which correspond to macroprolactin content in circulation and are considered to be biologically inactive. Hyperprolactinemia is the pathological condition where prolactin level rises above the normal range, whereas macroprolactinemia so far is considered to be clinically asymptomatic, having high levels of macroprolactin molecules in circulation. Etiology of hyperprolactinemia and macroprolactinemia includes physiological causes, that is pregnancy and lactation, hypothalamic prolactin stimulation, so many neurologic and antihypertensive medications, other neurogenic factors, increased prolactin production by the body, reduced prolactin elimination because of renal causes, and abnormal molecules which correspond to the hyperprolactinemia condition, besides other causes which remains unclear. The signs and symptoms of hyperprolactinemia and macroprolactinemia includes menstrual disruption, galactorrhea, infertility, reduced libido, decreased bone mineral density, and headache, including other visual problems. Osteoporosis. Hyperprolactinemia, which occurs because of pituitary causes, prolactinomas, and non-pituitary causes, results in hypoestrogenism, which correspond to increased level of interleukins, increased osteoclast activity, and reduced osteoblast activity, further resulting in thinning and weakening of bones, causing bones to be fragile and prone to fractures. This condition is called osteoporosis, which is quite well known with hyperprolactinemia. But what about osteoporosis in macroprolactinemia? This brings us to the rationale of the particular study, where there is no particular specific data on percentage of macroprolactinemia in hyperprolactinemia in the country. Further, the consequences of failure to recognize when hyperprolactinemia is due to the presence of macroprolactin molecules are significant, because so far macroprolactin is considered to be asymptomatic. Then osteoporosis is more likely to be a manifestation of hyperprolactinemia and not macroprolactinemia. Bone mineral density, therefore, could be a screening factor for macroprolactinemia from hyperprolactinemia cases. Based on this rationale, the objectives of particular study were to find out prevalence of macroprolactinemia in cases of hyperprolactinemia and to find out prevalence of osteoporosis in macroprolactinemia and hyperprolactinemia and its correlation with estrogen levels. We recruited pathological hyperprolactinemia cases having prolactin level more than 100 nanogram per ml to make sure that they were 100% hyperprolactinemia patients. Along with this, we also recruited physiological hyperprolactinemia and some controls with normal prolactin levels. All three groups were subject to PEG precipitation, followed by repeat prolactin assay for classification of hyper and macroprolactinemia cases. If the repeat prolactin assay was more than 25% of initial prolactin value, the case was considered to be true hyperprolactinemia case, whereas if they had less than 25% initial prolactin value, it was considered to be macroprolactinemia. And then some cases from both categories were subject to bone mineral density to study the prevalence of osteoporosis. So we recruited more than 100 hyperprolactinemia cases where prolactin was from 100 to 8,000, 50 physiological hyperprolactinemia cases, and 85 lactating physiological hyperprolactinemia cases, along with 25 controls. Initial diagnosis of hyperprolactinemia was done using prolactin assay kit. This also included taking relevant history, physical examination, initial hormonal analysis, sample collection for PEG precipitation. This shows the demographic and clinical profile of hyperprolactinemia patients. So then we classified the hyperprolactinemia patients based upon the cause of high prolactin, which gave us 4 broad categories: pituitary adenoma, 19% cases, 35% drug-induced hyperprolactinemia cases, 35% idiopathic hyperprolactinemia cases, and 11% cases with secondary causes of hyperprolactinemia. First objective was to find out prevalence of macroprolactinemia in hyperprolactinemia cases. For that, initial prolactin assay followed by incubation for 10 minutes with polyethylene glycol, followed by repeat prolactin assay. More than 25% recovery of prolactin, the cases were considered to be true hyperprolactinemia, and less than 25%, it was considered to be macroprolactinemia. So we found out of total 102 cases, the prevalence of macroprolactinemia was 21.57%, and there was none microprolactinemia case in physiological cases, physiological hyperprolactinemia cases, or controls. So the first part revealed that there were 21.5% hyperprolactinemia cases in macroprolactinemia cases in hyperprolactinemia. Then prevalence of macroprolactinemia in different categories. Among pituitary adenoma, 26% were macroprolactinemia, 73% hyper. 16% were macroprolactinemia cases in drug-induced category. Among idiopathic, there were 30% macroprolactinemia cases, and among secondary causes, there were none macroprolactinemia case. Further, we saw the details of macroprolactinemia cases, and we saw that cases with macroprolactinemia also had associated reproductive manifestations. So this table shows that 72% macroprolactinemia cases had associated reproductive manifestations. Macroprolactinemia is the sole cause of associated reproductive manifestation in 11 cases. But the comparison of clinical symptoms in macroprolactinemia and hyperprolactinemia cases showed that there was no significant difference in clinical symptoms between macro and hyperprolactinemia cases. Further, we saw that with proper treatment for high prolactin, macroprolactinemia reversed. So there were reversal of reproductive dysfunctions also in macroprolactinemia cases. So this shows build up. We can't handle it, dude. Macroprolactinemia seems to be responsible for reproductive manifestation in these cases. So the results of objective 1 are that the prevalence of macroprolactinemia is 21% in hyperprolactinemia cases. Highest prevalence was in idiopathic hyperprolactinemia cases. There was no case of macroprolactinemia in physiological hyperprolactinemia or controls. There were reproductive manifestation in 72% macroprolactinemia cases, and reversal of reproductive dysfunction was also observed in 5 cases with appropriate treatment for hyperprolactin. Coming to the second objective, to find out the prevalence of osteoporosis in macro and hyper cases and their correlation with estrogen levels. For this, we conducted DEXA scan, that is dual energy X-ray absorption hologenic discovery. And this was done at 3 sites for lumbar vertebrae, for left femur, and for left forearm. 2 sets of values were generated by DEXA scan, T-score and Z-score, in which values from -1 to -2.5 were considered to be in the range of osteopenia, and less than -2.5 was considered to be in the range of osteoporosis. So the results showed, this table shows comparison of T-score and Z-score between hyper and controls. And there is no significant difference, as we can see in the last column, for T-score or Z-score at any of the 3 sites. So this shows that T-score and Z-score did not show any significant difference between hyperprolactinemia patients and controls at any of the 3 sites studied. Next, we compared bone mineral density in different groups of hyperprolactinemia based upon the cause of hyperprolactinemia. In this, we observed that there was significant difference in bone mineral density at femur between cases with idiopathic and secondary cause of hyperprolactinemia. Next, we compared bone mineral density between macro and true hyperprolactinemia cases and controls. And the p-value shows that prevalence of osteopenia or osteoporosis was 50% in macroprolactinemia and 70% in true hyperprolactinemia, but there was no significant difference in macro and true cases at any of the 3 sites studied. Next, we compared hyper and normal DEXA scan cases, hyperprolactinemia patients with normal DEXA and those showing osteopenia or osteoporosis for the other causes, and like the gender, cause of hyperprolactinemia, post-peg prolactin recovery, prolactin levels, estradiol, BMI, duration of hyperprolactinemia, calcium levels, phosphate and alkaline phosphate levels. And in here we observed that BMI significantly was high in hyperprolactinemia cases with normal DEXA compared to those with osteopenia or osteoporosis. Further, we did the Pearson correlation analysis for BMI, estradiol, calcium, phosphate, and alkaline phosphate levels. And we observed that BMI was highly significantly correlated with prolactin levels. Next section shows BMI to be significantly positively correlated with HIP T-score and Z-score. So the results from objective 2 were that the prevalence of osteopenia and osteoporosis was 50% in macroprolactinemia, 70% in true hyperprolactinemia, and 60% in controls, which is statistically insignificant difference. Next, that mean BMI was significantly high in hyperprolactinemia patients with normal DEXA compared to those with osteopenia or osteoporosis. There was significant correlation of BMI with prolactin levels, total femur T-score, and Z-score. And lastly, that we did not find any significant difference in serum prolactin levels or estradiol levels between hyperprolactinemia patients with normal BMD and with low BMD. So from this, we conclude that prevalence of macroprolactinemia can be as high as 20% in pathological hyperprolactinemia patients. No macroprolactinemia case is found in physiological hyperprolactinemia cases or controls. Macroprolactinemia is found to be the sole cause of associated reproductive dysfunctions in 52% cases. So according to this study, we cannot say that macroprolactinemia is clinically asymptomatic. It is very much symptomatic and can also be treated with proper treatment for hyperprolactinemia. Macroprolactinemia, as the next point says, along with other factors, is responsible for reproductive dysfunction in 42.8% cases. 68.9% true hyperprolactinemia cases and 57% macroprolactin cases shows osteopenia and or osteoporosis in DEXA scan. That means, again, the difference is not significant. Both hyper and macro cases show DEXA scan, show weak bones in DEXA scan. Estradiol seems to be unrelated to osteopenia or osteoporosis in hyperprolactinemia cases. Further, calcium phosphate and alkaline phosphate seem to be unrelated to bone quality in all the categories of hyperprolactinemia. Finally, our data suggests that there is no benefit in distinguishing macroprolactinemia cases from hyperprolactinemia cases, as both are having similar problems and require to be treated equally. This is all from my side. Thank you so much.